I'm with the American Indian Alaskan Native Addiction Technology Transfer Center, the National Center here in Iowa City, Iowa. And today we have Dr. Kathy Tomlin and Kevin Tomlin presenting on motivational interviewing during challenging times, a two-part series. I'm going to go over a few orders of business announcements, and then I will ask for a volunteer to open with a blessing, and we'll go from there. I'd like to welcome you all. It's wonderful to have you here with us this morning or this afternoon, depending on where you're listening from. This webinar is provided by the National American Indian Alaskan Native ATTC, a program funded by SAMHSA. This training series is brought to you by the National American Indian Alaskan Native Addiction Technology Transfer Center. We are part of the ATTC network, which also includes 10 regions, 5 international centers, a network coordinating office, and the National Hispanic and Latino ATTC. This webinar is also provided by the National American Indian Alaska Native Prevention Technology Transfer Center. We are part of the PTTC network, which includes 10 regional centers, the network coordinating office, and the National Hispanic and Latino PTTC. This project is supported by SAMHSA, and the content is developed by the presenters, and the opinions expressed today do not necessarily reflect the views or policies of SAMHSA or Health and Human Services. In the next couple of days, we will send out a follow-up email to everyone who attended, which includes a link to the recording, the handouts of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs for a small fee. I believe today's 2-hour presentation, we will be able to offer 2 CEUs rather than 1, as is printed in this slide. I'll follow up with that, and we'd be happy to provide CEUs to you. Contact Natasha Peterson at the email listed here on this slide. As I said, we will be sharing a survey link at the end of the session today. We'll also make this available in the chat box to fill out during the presentation today or shortly thereafter. The survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. I know most of you are familiar with Zoom. However, just a few things to keep in mind. We are going to utilize the chat box for comments during the presentation. You will need to click on the chat icon. It'll open up the screen that's on the right side of your screen at the bottom. To ask questions or share comments, please type them into the chat pod and hit enter. You will be muted for the duration of this webinar. But again, use the chat feature to share your questions and comments. I will be monitoring this throughout the presentation along with my colleague, Kate, and we will try and address these as we go. We will be saving the chat box as a document, and I just want you to be aware of this as you enter comments into the chat box. We are going to be recording this session as well for future reference. Keep that in mind as well. Today's speakers we're really honored to have a friend and colleague of mine, Dr. Kathy Tomlin. She has been practicing in the mental health addictions field since 1974. In the mental health treatment prevention field as a counselor, administrator, educator, and consultant. Dr. Tomlin is committed to sharing her work with Native American communities. Part of her career is focused on the development of supervision and training initiatives to enhance the practice skills and professional development of professionals in the counseling and related fields, promoting evidence-based practices. One of those best practices is the teaching and supervision of motivational interviewing. She is a Cheyenne River Sioux tribe. She is a member of the Cheyenne Sioux River tribe and also has Irish roots. Again, Dr. Tomlin has been working in the addictions field, mental health field, and prevention field for decades, focusing on professional development and the training and evidence-based practices. Also with us today is Kevin Tomlin. Kevin is also a friend and colleague. Kevin is originally from, I think is it Puget Sound area. What is it?
Puget Sound.
Puget Sound
Yeah.
area. Yes, and now lives in Portland. He is currently working as an addictions therapist and practicing in various ways with members of the MINT community, which is a certified motivational interviewing trainer, national trainer, learning the ropes of becoming a high quality MI trainer. He's well on his way, trust me. I've seen him in action. Kevin walked with several teachers in shaping his voice as a therapist, retreat leader, and speaker, drawing on diverse traditions. Clinical training followed, and Kevin now focuses his energy on integrating his traditional spirit into professional practice. He is currently working closely with members of the Motivational Interviewing Network trainers to this end. So I want to thank both of them for being here today. And before we begin, I would like to ask if I believe Patrick Kafflooking is here with us today. I'm wondering, Patrick, if you would be willing to open the presentation today with a blessing.
Can you hear me, Steve?
Yes, I can. It's good to hear your voice, brother.
Yeah, thank you. I'd be honored to do it, Steve. But Creator Father, we just come to you today in the very troubled times with coronavirus all over the world. And we just pray, Father, that you protect each and every one of us, our families, throughout in the entire world, Father, and make us all safe. We pray for our families that we left at home. We pray for all our children, all our ancestors, everywhere they may be. We just pray, Father, that you will come together as a universe, as a nation, and forget about color, race, and everything. Just join hands around the entire world and say, become one as what we are. And I just pray, Father, that from the bottom of my heart, that all nations will come together, and we'll pray that the scientists will find a vaccine that we can check this virus that's going on. And like I say, I'm so blessed that to be here with all of you wise men from the east, west, north, and south, and the ladies as well. And I just hope this is a great learning, Steve, and I really thank you for allowing me to talk to the folks and give you the blessing today. And we just ask this through the Jesus' name. Amen.
Amen.
Thank you, Patrick. Just adjust your camera down a bit, brother, so we can see you. It's good to see the top half of your head anyway.
Oh, okay. That's probably
There he is. There, that's a little better.
How you guys doing? All right, thank you.
See you.
Oh, yeah. There we go,
there
right
he
there.
comes. There he is. There, that's better.
All right, thank
There's the
you.
face I remember. There he
All right,
is.
thank you.
Thank you very much, brother. Thank you very much.
Bet. Thank you.
With that, I would like to begin this event and turn the floor over to Dr. Tomlin. Thank you.
Good morning, everyone. It's nice to be here. This is my first attempt at doing this type of format, so please give me lots of feedback and let me know what's going on. I want to keep this an engaging activity. Now, see, I want to get this up so you can see the whole thing. So we're going to start there because there's lots of pretty pictures in here. I want you to get the full picture here. Really nice to have you all here, and I can see some friendly faces out there. At least you look friendly. And I hope that this time together will be useful and helpful. And please, we want to keep this as engaging as possible. So please use the chat box and give us questions, comments, feedback. I built it into the slideshow, but that doesn't mean that you can't do it anytime. So we'll get started. Part of the approach to this is really to try and get to know where you're from, and then hear from you what your experiences have been with what's going on out there in the world. So I wanted to start a little bit with just take a look at the map and let us know where you're from. So we have a sense of the community. And if you wouldn't mind thinking about one thing that you would like to address during our time together. We'd also like to know who's already been exposed to motivational interviewing. Let me change already this format. And how are you spending your time during this pandemic? What do you do in normal times? What is your favorite thing about spring? Just to kind of get us started. So if you wouldn't mind just commenting either in the, can we do sound, you guys? Can we do some sound? Or is it going to be through the chat box?
Have a good one.
It's been unmuted. We're going to have a lot of background.
Okay. Let's do that way. You are muted. Alt-A to unmute. You're unmuted by host. Okay. So let's hear from people, either through the chat box or however we can do this. Where are people? Let's start with.
Sorry, I
people Go ahead.
Oh, sorry, Kathy. I was just going to say, I will give participants the option to unmute themselves. So right now we've got you all muted, but if you want to jump in and say something when Kathy gives you a chance, feel free to unmute yourself then.
Wonderful. Thank you. I've got a number up here in the corner, 61. So who would like to offer a comment about the check-in questions? And let's start with where you're from.
Again, you can unmute yourself by clicking on the blue box in the top right-hand corner of your view screen, or in the lower left-hand corner of your device.
I see some people from Arizona, Medford,
yes.
Oregon, been there, Kansas City, Fort Lauderdale. Rosebud, been there. Hello.
Yeah, the group is telling me, Kathy, they're not able to unmute themselves. So we
Okay. As long as you can hear me, I'm seeing many Ojibwa from Minnesota. My grandfather was from Minnesota. Colorado, Chippewa, Cowlitz, Longview. Hello, neighbors. Hi, Vermont. Welcome. Thank you for checking
Hello.
in. That's wonderful.
Yes, I think I've made an adjustment. You should be able to unmute yourself now, everyone.
Hi, can you hear me?
Yes.
Yes.
Hi, my name is Vincent. I'm from New York. I work at a hospital in Yonkers, St. John's Riverside Hospital. One thing that I am doing during this pandemic is I actually am still working. I'm a patient navigator. I've had some trainings in MI in the past, within the hospital and some training facilities within New York City.
Wonderful. Thank you so much for all that you're doing for us.
Hi, can you hear me? My name's
Yes.
Carol Cruz. I'm from Connecticut. I was just putting in there a couple times. I put in the hand raising feature that might help. You can see when people raise their hands.
Yes.
So I am a peer recovery coach. I was just actually on a training doing the RCA, the Recovery Coach Academy. And we were actually talking about motivational interviewing. So I've been doing it for several years. I absolutely love it. It helps me to walk alongside of those that I'm coaching.
Yes.
I'm experiencing, I have, as of Monday, I found out that I am COVID positive. It took me 22 days to get an order from my doctor. I can't tell you how frustrating it has been, and I have had all the symptoms for the last month. So yeah, I just have been staying busy but resting.
Bless you for being here today.
Thank you.
Lots of experience. I'm seeing through the chat box a lot of experience. So I appreciate those of you. We have a lot of co-trainers. Yeah.
Kathy, your voice is warbling a bit. We're not sure. I'm not sure where that's coming from.
Okay. I don't know what I can do because my speakers aren't working. It could be me too, that, you know, I tend to speak funny. Can you still understand me?
Yeah, it's very warbly though.
Yeah.
It's not you, Kathy. It's
Sounds like a connection.
yeah. Let's see if we can try your headphones with the microphone in them, because it sounds like it's the computer is doing something weird to your voice. It's making sound.
I don't know if that helps. I just put my headphones in, but I'm having trouble connecting with them.
Okay, when you go down to the microphone icon, the little arrow right next to it, does it show those headphones as a microphone option?
I'm looking. I'm in the PowerPoint right now.
Oh yeah.
Okay.
That's
I'm over at the mute. Is that where I'm looking?
Yep.
Yeah, we may want to mute everyone again too. Someone is suggesting, Paul is saying it might be because everyone's off their mute. So let's try.
Okay, I've tried that here. Let's see what you sound like, Kathy.
Testing.
Yeah, we're still getting that weird feedback.
Kathy, you may have to call in by phone so we can get a clearer signal.
Okay.
Yeah, we can try that.
Let's see if we can send her the number, Kate, that she can
Yep,
call.
I've got it.
'Cause your voice sounds good. Carol's voice sounded fine. If there's something going on with Dr. Tomlin's voice, everybody bear with us here.
I apologize for that. I don't know what's going on. It was working really well yesterday, but
Okay, I just put
That's okay.
the phone number in the chat, Kathy, and then in the meeting room number.
got it.
Okay.
Yep, if you can dial in, Kathy, that should allow, then you'll just have to mute
Okay.
your laptop so you don't get an echo. That might be the best route to go. Thanks, everybody. Yeah, Kevin's just reminding to hit pound after you hit the meeting ID. Bear with us, folks. We're going to get there.
Are you a 503 number, Kathy?
Yes, that's her 503. Yeah, now you have to turn down your
I know,
sound.
I'm in my PowerPoint. I'm trying to get out of it. There we go.
Just mute yourself. You have to mute your laptop.
Oh.
Turn off
Okay,
your
there we
speakers.
go.
Hey.
Okay, you saw my intro,
Oh.
1974, so you know I am an oldster, and sometimes it takes me a while to get this technology down. So I
We're all
apologize for that.
Thank you.
Yeah.
Figured out.
Okay. Thank you all for participating, and I've already moved forward in my presentation. I'm not quite ready to do that yet. So I'm moving backwards so I don't miss any slides. There we go. So it sounds like several people have had experience with motivational interviewing. And if somebody's brand new to it, that's okay too, because I'll be going over some basic concepts. And go ahead and write in the chat box if there's something that you particularly would like to get from our webinar, either today or next week. And we want to keep you engaged. We don't want you to get bored or multitask and miss something. So just let us know what's happening for you, and we'll keep that process going. So thank you for introductions. Okay, I'm going to move forward on what we're trying to accomplish in our webinar. Now, normally I do 2-day workshops on motivational interviewing, and so we're adapting this for this format, and so we're going to do the best we can. But one of the things that we were thinking about is what's happening with our people related to epidemics and what's going on right now. I've gotten some feedback from some people around what their concerns are. I've identified, because of a brief intervention format, I'm kind of going to be mixing and blending the counseling version of MI. If you're a substance abuse counselor or a mental health practitioner, and the behavioral health version, which is you get a brief intervention for maybe 30 minutes, or even if someone's in the correctional field, you might get a brief single session of motivational interviewing. And I'm trying to address both of those through this webinar. And as we've talked, we want to hear from you as well. And any feedback you have or any support you need, please let us know. There's a lot of people on this webinar, so there's a lot of experience and there's lots of resources, and I would love to share that with everybody. So I wanted to start our talk today with what I did some research and found what's the history of epidemics in the United States. And this slide, you start at the top, 1633 to 1634, smallpox from European settlers, which was one of the most devastating experiences for Native peoples, where whole tribes were eliminated from the smallpox epidemic. And throughout the history, you'll see the various types of epidemics that have troubled our country from way back. So yellow fever, cholera, scarlet fever, typhoid Mary, the Spanish flu, which people are often referencing for today, diphtheria, the peak of polio. Now I'll share a personal note. I had polio. I'm a polio survivor, so I was part of that. I got it late. I got it in 1955, so the vaccine had come out, but I was not in the group that received it, so I ended up getting polio, so I know that experience. Second measles outbreak, HIV, the contaminated water in Milwaukee, whooping cough, and now coronavirus 19. You'll see where I got this information off down below. So that's pretty. When I first read this, I thought, wow, that's a lot. And of course, healthcare inequality affects people of color more often than the Anglo population. And so certainly, when these waves come, it certainly affects us in very deep and profound ways. So just take a minute and look at that, and I'll just we will get you the slideshow with this in it, as well as the reference. I'll share with you, when I first saw this, I got really sad looking at this. And then I had a thought that, wow, what survivors we are. So that was kind of a two-pronged experience that I had looking at this. Present day. This is from the Center via the IHS area. You'll look at what's happening, particularly with Native American peoples. Now, when I first started putting this together, it was back in March. So you'll see March 30th, and you'll see the numbers at the bottom, and you'll see the areas that the Indian Health Service area covers. So you'll see the people tested positive, and those negative below. And I thought that was a lot, but then I updated it for our presentation. And if you look at our update, from 3,083 tested to 11,000 tested, positive 165, 1,037. So that's a 2-week period. That's a jump in a 2-week period. Huge. And then, excuse me. And then 8,000 negative. So it's only 2 weeks, and this is what happened, which is profound. So let's just pause a minute and share some comments, reactions, or questions you might have. And let's see, let's go to the chat box for that. Steve, are you there?
Yeah, I sure am. There's quite a few comments coming in. There's Carol's asking about the opioid epidemic, how it's.
Yeah,
it's affected,
actually Yeah. 300,000 people in the last 20 years.
Mm.
Yes, I'm sorry, that I did not include that because the opioid population are the young adults that I worked with primarily in my career for the last 10 years. So that's a miss on my part.
We
But
can
good
add that
point.
in the timeline. Mhm.
Yes, I think we should. In Oregon, it started roughly the epidemic in Oregon started around 2006, and then it's another part of the country.
I know Sheila's asking about the statistics, including, do they include Billings and all the tribes in Montana?
Yeah, I'd have to look at the IHS website because that's where I got this information. But probably, but we could check that out. Anyway, yeah, it's pretty
good,
profound.
And
Richard
Paula,
likes how the negative results were posted. It gives hope. Good point. Thank you for that.
yeah, and Paula Carter asks, what's the difference between an epidemic and a pandemic?
Yeah, good question.
Is it just a matter of geography nationally versus globally?
Well, pan, I think it's either a Latin or a Greek word, and it means all over. And so pandemic is an all over, which is a worldwide phenomena. And epidemic is more local. For example, the opioid epidemic in the United States is pretty profound, but it's not all over in the whole world. But that's a good example.
Yeah.
And that's how I think about it, is pan, because pan, I took Latin in high school. I was forced to. It wasn't my choice, but it turns out it comes in handy every once in a while, and it means all over, and that's the difference.
Anyone has wants to make a comment verbally too, I think we have lifted the, you should be able to unmute yourself if you have a comment for Dr. Talman.
Oh, do we believe that COVID-19 positives are accurate? No, I don't, Carolyn. That's a great question. I think it's underrepresented, probably. So, I mean, just like it is in the U.S., it's probably because we don't have the testing capabilities that we should. And in fact, in some communities, Indian communities, it's pretty, it's not even available or very sparse. So yeah. Okay, well, this is what I've heard, and I've heard this from a variety of resources about what people are saying, where this pandemic is affecting them, being away from family, especially their family elders, bringing their illness. For those working currently, particularly in healthcare or other essential services, bringing the illness to their family or others that are living with them or close to them, wanting to stay connected and how to do this. Some people have technology, some people do not. Some people are feeling anxious about that. And how are people managing their chronic care issues? Are people, there's a lot of worry and concern often about others, and is that creating any trauma triggers for them? One thing that has come up is the incident of depression, and what do you do with domestic violence that might be increasing? Having enough resources, including from the federal government. It's been pretty sparse, although it's getting better, but it's still not what it should be compared to others. wanting to protect our elders who carry our stories, culture, and history in terms of not losing that. What are some other things that you're hearing from your communities that you're processing in terms of your worries for them or for yourself, for that matter?
Looks like Justin, is it Meal or Mel? He has his hand raised. Do you have a question, sir, for Dr. Tomlin? Justin M. And Doc, you can check in the manage participants window. You can look to see if hands are raised. That's how we want to use that feature. I saw Justin had his hand up, and Carol Cruz also had her hand raised in the participants box.
Yes. Paula has a comment. Feel free. Okay.
Yes.
I'm in the more section, so. And then I do see Justin's hand raised.
Yeah,
so,
I see. We can chime in. If you have your hand raised and want to unmute and ask a question, that's fine. Or you can go to the chat box.
Paula, go ahead and type in your question.
Oh, somebody
or comment.
Looks like we can't. Okay. I have switched that feature. You should be able to unmute now, Roy.
Hello.
Hi.
Hi, this is Paula. I just have a comment, and first of all, thank you for putting this together. It's wonderful. I'm from Turtle Mountain, Band of Chippewa from North Dakota, and I've been in contact with my family there. And one of the concerns I'm hearing from our community members is that if they have an elder, especially that gets sick, that they're not choosing to take them into clinic or hospital because their fear is if they get sick and possibly die from this virus, they'd be alone. And they said that's not a chance they're going to take. They want to keep their family member at home so that they're not separated. And so they're choosing to keep them at home as opposed to bringing them to the clinic or hospital if they get really sick for fear of them dying alone. I know I've heard that concern several times.
Yeah. Wow.
Hello. Hi, this is Roy.
That's great. Hi, Roy.
I just had a comment from based on Sheila's question that she asked earlier about the data on there. I'm with Rocky Mountain Tribal Leaders here in Billings, and we have the Epi and Tech Center here. This is a really challenging thing to do, is get all accurate data in there. One of the sources that that's really good for getting data outside of IHS and other areas is under the NSSP program. It's the CDC National Surveillance Program. All but I believe it's 5 states in the nation participate in that using the Essence system. If you contact your state here, it's Department of Public Health and Human Services Epidemiology. That data is open and public. It's based on CPT codes that are reported to CMS through the emergency rooms, hospitals, and doctors. And they can pull that data out. Literally, it took me less than 10 minutes the day before yesterday.
Wonderful.
To get all the data on naloxone overdoses in the state and then sorted out by AIAN populations. So they are really good about that here in Montana. So if you look at the IHS data in conjunction with that data, you kind of get a clearer picture of what's going on for the tribes both on and off reservation, which is what you really need to look at. So I just wanted to throw that out as a resource, and if anybody needs to get a hold of me, my contact information is here as well.
Wonderful. Thank you for that.
The chat box, Roy. Thank you.
Teresa, I think for prevention to utilize this as opportunity to reach broad issues that compound and create the circumstances our communities are facing. Yeah. my thought from what Paula said is using a motivational approach to talk to the relatives and help them resolve that concern so that their loved one can get the best medical care possible. One of the issues for healthcare providers and families is not having enough protective equipment. So that's why family members can't be in there. I'm wondering if anyone has any thoughts about what Paula said. That hit me in a pretty profound way, and it's very not only for our people, but also for people that are dealing with a loved one that is dying in a hospital setting and they can't be there for them. And the medical professionals have been talking about making sure that they communicate with their doctor and that the doctor makes a concerted attempt to be present with somebody, which some medical providers are willing to do. So how can we get them the best help medically and address that issue of the potential for someone passing from this illness? So if anyone has any suggestions or thoughts, I'm thinking it through as I am thinking about how can a motivational approach help all the way around. And I hear a story about a physician who talked with the family members, and he was present with their loved one and on the phone with the family at the same time when the loved one was towards the end of his life. But that is something for us to think about. And I didn't want to let that pass without us thinking about that, because that's what's happening. Wonderful. Okay. And there's a long note that I want to.
Yeah, that's from Teresa. Teresa Salt Frill. Good suggestion.
Can I jump in, Steve?
Yeah.
Of course.
Okay, so under the Grant Sampson CDC right now, agencies can move money around to purchase information technologies for doing telehealth. And what I've seen one agency do it's not a tribal agency, but it would definitely be within the realm of that. It's a convalescent home. They actually use some of their money to purchase iPads and or phones for within the agency, within the facility use. You can't buy those for clients outside the facility, but you can buy them for clients inside the facility. And they set those up and are making sure that the person who is in there, if they're able to talk and things like that, have access to an iPad, phone, something of that nature, so they can do video calls with their family members and stay in touch real time that way. And your money can be used if you're purchasing them for your agency use inside your agency, if that's a clinic or hospital and someone's in there. I know down at Crow, we actually have a convalescent home down at Crow. That can be purchased for use inside that under your grants. And you can do that without requesting any changes, because you have 25% of your grant you can move without prior authorization. And they're really pushing that right now through both the CDC and SAMHSA.
Wonderful. Trouble, yeah. Thank you for that.
Thank you, Darlene, for that comment. That's an issue with a lot of facilities.
Yeah, Darlene, tell us a little bit more when you say trouble with our program accepting new clients. If you want, no pressure. Okay, let me just review. I'm going to move on because of time. There's things that, thank you all, by the way, for the comments. And Roy, thank you for that specific information. This is a kind of a schema of what happens with complex trauma. And this is related to mental health and substance abuse issues and how the trigger of historical trauma affects people. And I had a comment from one friend that some people don't like talking about this, and some people like what happens is they show it instead of they talk about it. And as healthcare providers and mental health providers and substance abuse providers, we see this all the time, but it may not be spoken. But this is kind of the vicious circle. And part of motivational interviewing, what it does is it gets people out of this vicious, traumatic circle. So creating a healing environment, here are some trauma principles. Some of you, probably most of you already know this and have been working with people on that. But here are some examples of some principles to be, and you can break these down, each one of them, and create through your own communities ways that you can make the principles come alive for you. And as I look at these, I think, oh, well, a lot of these emphasize control and support for the client. That's a motivational interviewing calls that. Respecting people's autonomy, creating collaborative relationships is MI, is part of the spirit and style of MI. Value cultural competence, values clarification. All of these things are consistent with an MI approach to working with people. Healing values, I probably don't need to go back to this for people on the call, but just a reminder of the generalized healing values, not the tribal or village specific practices. So why motivational interviewing? Here are some thoughts about that. To contrast it with healing approaches, MI approaches offer validation. They provide calm and support when people are experiencing doubt, worry, depression, or other troubles. Connection with others, a conversation between two experts is one of the principles or the beliefs. MI can focus a person's experience so as not to overwhelm someone with their troubles. In other words, one of the key change processes in MI is the notion of focus, and we'll talk about focus, and particularly with the brief intervention model, focusing on a target behavior. That's what MI says, or a specific important behavior in the here and now can make a difference for people. And I'll talk about the spirit and why for Native communities, MI is confrontational and non-interfering. It uses active listening, teaches culturally, can support the culturally appropriate idea, emphasizes relationships, and one of the most effective uses of MI is to increase hope and optimism through the relationship with the person, where respect and affirmation is offered. Okay, so I wanted to start our spirit conversation by having this, inviting you into this exercise. If you could think of a person in your life who has inspired you, helped you to become the person you are today. It could be someone in your life now or someone from your past, a parent, grandparent, aunt, uncle, coach, etc. And as you think of that person, try to see them in your mind, what they look like, how they sounded, what they might have said to you that you particularly remember. And I'm going to give you about 2 or 3 minutes to do that. And then I'll ask you to do another piece. So I'm starting now, time-wise. Okay, now hopefully you have identified somebody. Next, what I'd like you to do is write down or think of some traits or characteristics that they had that made that difference for you. For example, were they kind, accepting, funny? Did they listen well? Help you think about something that was troubling, offer support, encourage you, something else that made a difference for you that helped you in your life. So as you see that person and experience that person in your mind, think about what it was about that person that helped you in your life. And then just jot down or think about some of the characteristics or traits that they had that were particularly important to you. And I'll give you about a minute to think about that. And then let's hear what people have. We'll go to the chat box and hear what people have to say.
Yeah, there's some nice sharing coming in the chat box.
Okay.
So Darlene says characteristics were being accepting and non-judgmental. Oh, this is great. Thanks for sharing some of this, everyone. Unconditional love and listening, says Sheila Hurd. Good to see you on the call, Sheila.
Good storyteller, strong woman, clean slate. I like the one that accepting and also challenged me or pushed me, from Tracy.
Mm-hmm. That's wonderful.
That's my timer that doesn't, of course I ignore it, but resiliency and connecting. My past does not define who I am. So true. Wonderful. Hey, there's a Tomlin there. A Tomlin son.
It's close. That's close, isn't it?
It's close.
Ellie
When you know better,
says,
you do better.
Ella Driscoll says they taught me the importance of resiliency and connecting to others. That's great.
Yeah. Wow.
That's just great.
Just presence. Ashley, I don't know if I'm saying your name right. My dad was my favorite person. And my grandfather, my white grandfather from Minnesota. He was a loving, kind human being. Wonderful. I wish we could just cut and paste this section right here and just read it every day when we're dealing with the challenges of this pandemic. Yeah. Thank you all for sharing.
Thank you.
Keep sharing. Thank you so much. I feel like this is the best part of my day today, and I'll remember it throughout the week, I hope. Okay. So spirit and style of MI, let's take a look. Partnership, collaboration, acceptance, compassion, connecting with personal wisdom, otherwise known as evocation. Evocation is one of those words that people don't quite understand, so I decided to rewrite it a little bit, but basically it's calling forth the best in a person. And I noticed on the comments that a lot of the spirit and style that you experienced with your important person is what MI practitioners offer to the people that they're working with. A way of being with someone, helping a person resolve ambivalence, not that the practitioner does it for them, elicit quiet, bringing forth, understanding. This idea of spirit in the practice of MI is the foundation for everything. Without it, it's not MI. MI, it's a hard thing to describe, but I think you guys did a great job in your comments on the chat box. And so it's this understanding that you are that person for the people you're trying to help, that you show those same kind of characteristics. You're kind, you're accepting, you offer compassion, you affirm, you support, you listen. And the difference between a global spirit, just being with somebody, and motivational interviewing is motivational interviewing actually has a direction and an agenda. And its direction and agenda is to help somebody with something in their life that they feel two ways about while you're being in spirit with them. MI proposes that there are 4 key processes to change. And if you'll notice at the bottom, it's engagement. And engagement starts with spirit and style, and that attitude and presence with somebody. And then it moves to focusing around a couple of specific behaviors. We'll talk about that later on. And then it moves to calling forth the wisdom of the person that you're working with while the practitioner is providing direction and their expertise. And then finally to making a commitment to plan for a particular change. So you start with the first one, which is engagement. Listen, understand where the person's coming from, focus on the person, not us as experts. In medicine, the way you would do that is you do let them know that you have a particular expertise to offer to them, but you would also in spirit say when they're ready, are you ready? Would you like this information? Versus just offering it and starting to lecture at them, I guess, versus help them to understand what's most important to them and how your expertise can help them get there. So here are the core skills. A lot of people think this is MI, but it is actually, it's not. It's just client-centered counseling skills, and it's a tool that MI uses to exercise being client-centered, individualized care, working with a person in spirit and style. So I'm gonna just break those down. For today, I wanted to get to open-ended questions and reflective listening and just look at a case study in terms of how to apply it. So I'm gonna move on, but I'll let you guys tell me through Steve if there's a question you have, because I'm on the PowerPoint and I'm not in the chat box. So if somebody wants to ask me particularly a question or make a comment, just let me know.
Video.
Okay. This is something that's kind of interesting, this idea of open-ended questions, mainly because we think that our questions are open, but often they're not. And the difference is when you ask, I think from a cultural point of view, some people might think this is rude to be asking a lot of questions. So part of it is listening and then following up with somebody when you hear that ambivalence, the feeling of out of balance or disharmony. And so you start with, I'm here for you. Let's hear what your concerns are, what's challenging for you right now, what your interests are, or your experience. You know, what is your experience right now? And then the practitioner would use listening to follow and to let them know that you hear them in spirit and style. You're offering that acceptance, non-judgmental compassion, affirmation, and support. And then before you ask a question, you would say, I have some thoughts, or I have some questions. Would that be okay with you if we pause in the discussion and I can give some more information? Open-ended questions require more than a yes or no answer. So if you're getting yes or no or maybe or I don't know, which is the common one, the younger age range, then it's because the question wasn't open enough. There's a value in MI to having more open-ended questions than closed-ended, but all questions are fine. If you want to have a conversation, open questions tend to be more likely to be an open conversation. Closed questions will shut down a conversation, possibly, unless you're in a medical setting where you do have to ask certain closed-ended questions like how old are you, does anyone in your family have health issues that I need to know about. Those are closed questions, but appropriate in a healthcare environment. So a lot of it depends on your context and what amount of time you have to work with somebody, and whether it's a one session with somebody or it's potentially multiple sessions. What you're looking for in the initial engagement process is any kind of specific behavior that people feel out of balance with, so that you can help them with your expertise create less disharmony and help them to move forward towards a change process, is the translation. So what are some of the usual questions you might ask and are a way to invite someone into a conversation about changing a certain behavior? For example, we could use the not taking your loved one to the doctor. That's a specific behavior that if you as a healthcare provider are concerned, or a counselor are concerned about that, that is a very specific behavior that you could offer spirit and style while you're asking them more about their openness regarding getting help for their issues of being connected and present with their loved one, so that their loved one can get the best medical care possible. And that's an example of feeling out of balance with that issue. And the value is to be with that person. That's a particular, so I might start the conversation with, you're saying things that are very, very important for you and your family, and I want to respect that. And I'm wondering if you're also concerned about your loved one getting the best health care possible. Would that be something that we could talk about, or something like that? So any thoughts about that? And I'm going to the chat box, so give me a minute.
Yeah, Jamie, Doc Jamie Strickland says he or she offers the question, how is that working for you, as an example?
Yeah.
Asking the patient, how is that working for you? So that's one thing in the chat box.
Yeah, not in the Dr. Phil way. with the condensate, you're not talking down to somebody.
Yeah. Jamie says tone of voice important, not to sound condescending.
Yeah. One of the key skills in MI, which a lot of times we forget to do, especially when you feel pressured by time, is asking permission. And very important, Steve's mentioning that, it's very important for us to remember always to check to see if the timing is right for a conversation, and if what you have to offer is a person ready to hear what you have, to avoid that. Do you want to talk more about that? Okay, that's an example of a closed question, but it's acknowledging the timing. You're sharing something with your therapist, and he or she is saying, is this a time that you want to talk about that? Making the person feel important, absolutely. Yeah, no judgment. Which is spirit and style. I know it sounds like, those of us who are trained in counseling, you could say, well, sure, of course. But often we're anxious to give our wisdom to other people, and it may not be that wise for them because we're not thinking about them. We're thinking about us. Yeah.
Teresa Saltbrill makes a great question, or a great comment too. About regarding Indigenous people. She says sometimes Indigenous people that would hear you due to talking about coming spirit, then talking on medical care might cause the individual or family to pull away. I don't know.
Absolutely.
If you want to chime in and talk about that a bit more, I think it's a great example.
Actually, we have a case study. I'd like to get to the case study, but Teresa, hold that thought, because I do have a case study where that was, I had an elder. Well, we'll get to it. Okay, so I'm going back to the slideshow. Maybe. Here we go. So this, the other thing is this idea of expressing empathy, which is also a very key concept in motivational interviewing. And this idea of reflecting what your client has said, verbal and nonverbal. It could be a nonverbal gesture where you're nodding, or you're just being with somebody, you're sitting next to somebody, and helping that person. You're communicating to that person, both verbally and non-verbally, that you have empathy, and they can feel that you are empathic when you're talking with them. So in MI, reflective listening is it's probably one of the most key components of skill in motivational interviewing. it can be from a cultural perspective, it can be used in a bad way. So we have to be careful how we use reflections verbally. My experience is when you, like, if you're in a talking circle, there's a collective synergy around when people are talking. There's a sense of empathy that I experience when people say a word, or they nod, or they lean forward as a group, and you can feel the empathy in the room with what someone's saying. One-on-one, it's different, and it's how do you engage with somebody to show that empathy. But it is a key component of motivational interviewing. So one of the skill sets is using, when you're doing verbal empathic reflections, here are the thoughts about it, is that whatever you're reflecting is about that person and what that person has said versus what you think or your opinion about what they said. So usually a reflection will start with you. You are, you feel, you have. It's not a questioning. Reflections are statements. They're not questions, with high empathy, spirit and style. And to be humble, in that you might see something and share it with that person, and to be okay with you being wrong about it. Part of doing good reflections is being in sync with somebody, and if you say something to them that's off for them and they communicate that to you, that you go with it, and then you say, I think I got that wrong. So being humble with the person one-on-one. Okay, I wanted to finish our time today with looking at a couple case studies, and I only wanted to focus on, for this 2-hour section, empathy, questions, and reflections. And if I was live with you, I would say, are you ready? And so I'm going to say, are you ready? And go to the chat box. But the case studies, there's 2 that I have for us to look at. And okay, and then the practice time is the questions there. And then I'm going to, yeah. And then I'll get to, okay. So we have 2 case studies, and take a look at them. Wendy, a 44-year-old Cherokee woman, comes to your clinic fearful for her husband, whom is ill, anxious about the new illness. They have underlying conditions. She lives outside her tribal community, in the suburban community, in her own home. And then there's Daryl, 67-year-old Tinglet, help me, people from Alaska, elder, whom was asked to come to the medical clinic for heart and diabetes checkup. Daryl reports feeling the pain of his villagers and wonders what Western medicine offers community. He does not feel he needs a checkup, but he's coming to calm his family concerns. The latter one was actually an experience I had in Alaska, where a woman, a villager, the villagers were suspicious of her Western knowledge, and she was trying to take her Western medicine into the village as an adjunct to what village customs were. So that's actually was kind of a real life experience that I had with her. And she wanted to take MI into the village, so, and lots to help with the substance abuse issues. Okay, so these are our case studies. Let me go to the chat box. Steve, you tell me if there's any questions.
Yeah, I'm fielding, there's some general questions, Doc, about just about some spirit of MI and kind of the approach.
Okay.
maybe if you want to, the group wants to just take a look at these case studies, digest them for a minute, and then post comments.
Worry about herself.
Mhm.
Like, yes, it's part of it, but behavior is just not okay. Like, why is she still testing positive for the drug use? Let's focus on that. Like, you know,
Yeah.
yeah, but they feel that whatever I know that I'm gonna pass it on to. I go, well, that's a given with anybody. Like, I have to report that.
Yeah, it's all because you report to the courts. What we do with the kids is anything that happens, good or bad, like you said, we have facts, then we have to report it. It's not something that we can just put under the rug and be like, oh, okay, she's using, oh, okay. We can't do that. I mean, she's a
Here's
ward
a
of
trick
the,
about that. Are you working
and under
with,
our custody, but a ward of the court.
So
yeah, and there's a trick.
Are you guys asking for her to have another worker, a separate worker? What is it that you guys are asking for? I said, because this is what it is. She's pregnant. She's a ward of CP. I told him she's under CPS, so therefore the child will probably be under. It might be under CPS, it might not. It just depends at that point in time. All this will probably determine that. I'm not going to make that decision. I go, to me, that's a conflict. This is something that management, you know, we are talking about it because we haven't had a case like this. And they brought up, well, can the current placement take her and the child? I go, yes, we've talked about that. I said, but the placement has to want to be able to care for both. I go, in Maria's position, she wasn't able to care for both. So that's something we need to disclose at time of selecting a parent or anybody willing to take her. Like right now, the place she's at, I'm sure I haven't asked, but I'm thinking they're willing to take both her and the child.
Yeah.
So they want to.
Hi, Kelly.
Natalia, you're echoing a bit. Let's see if Doc would like to. Kathy, would you like to respond to that? Or your thoughts?
Yes. What I'm hearing is a mixture of expectations placed upon the staff, kind of in conflict with maybe what the family or the individual is experiencing, which is very common. And I think you can still use a motivational approach with that without being confrontational, or there's a way to do it where you involve the person in the problem solving, even though there are restrictions, even though there are expectations, and you do it in a way where you're honest with them, because you're being honest, there are restrictions, but you do it in a way with helping them to understand the limited choices that they have, and that you're really there to help them and to help them deal with the reality of what's going on in their life and the expectations that are going on for them. So sometimes in life, we are not always getting to do what we want to do. And if somebody's using, and I'll take that as an example, the way you would deal with them in a mandated situation would be to acknowledge the reality of the mandate, and let them know that you're here to help them work through the mandates that they have. And you also have to be honest about what your role is with them, and that you have limitations too, just like they do. But how can you work together for them to negotiate the limitations and be more in control of the reality, because they're still making decisions. they're still choosing certain ways of being or acting that either can exacerbate their situation or and make it more tolerable. And MI works very, very well in situations like that. I don't know if that's helpful, but I worked with young people most of my life, and many of them were mandated. And there were expectations upon me to communicate with their probation or whomever, their family, the school, whomever. And I always spent time with that person, helping them to work through the fact that they're mandated and there's a lot of expectations placed upon them. When there was a using situation, I actually told them that it would probably be better for them if they took ownership for that using event, but that I would be there to support them while they were going through it, and also as part of a recovery process that sometimes people will use in a recovery process. So help the probation system allow that person to continue in care while we're working through their normal ambivalence about whether they should use or not. That's a normal thing. And so systems sometimes need help understanding that while the client's trying to make sense out of what they really want to do. The bottom line is that people still have choice, even in what seems like choiceless situations. MI is really a good practice to keep that person with you, and they can benefit more from accepting the choices that they're making. And our job is to, you know, is that a good choice for you? If so, how does that mesh with what's happening in your life, etc. So those are some thoughts I have about that. And I don't know the full context of the situation either. So.
Thank you, Kathy. Let's keep moving, perhaps.
Okay. Well, let's take. I like the comments about the specific case that Natalia was talking about. But let's talk about go back to the slideshow and look at the case studies. So I want you to just pick one of the case studies. Don't pick both of them, just pick one of them. And I want you to consider, take some time, if you're talking with Wendy or Daryl, how would you introduce yourself? And you might want to write this down. What would you actually say to them? What are some of the open-ended questions you might ask? And give us some examples. And once you ask that question, imagine what you might be reflecting back to either how do you know if you're accurately expressing empathy to him or her? So just pick one of the cases and spend some time. If you happen to be on the call with a coworker, it's nice to share with that person. Otherwise, on your own, just think about how would I introduce myself? What are some of the typical open-ended questions I might ask them? What kind of reflections might you be giving? And how do you know you're being empathic with him or her? So I'll give you about, I don't know, maybe 4 or 5 minutes, and then we'll go back to the chat box.
Thank you, Dr.
I'm going to start my timer.
Yeah, and I'll watch the chat box, and got some great comments coming in. So
okay, wonderful.
I see some nice comments coming in. This is really good. You guys are right on with this, with some of your open-ended questions.
Okay. Yeah, let's see what people have to say. Start with Sherry. Hello, Wendy. I'm Sherry. I'm so glad you're talking with me about your fear regarding your husband. Anyone in your perfect. Yeah. Is it okay if I ask you more about your concerns? Wonderful. Thanks, Sherry. That's a good start. Mr. Darrell, you said you came in. Calm some of your family's concerns about your physical health. What are these concerns? How important is it? Yeah, absolutely. Thank you for coming to the claims. What do you know about COVID? Perfect. That is a typical medical intervention. When you have a time limit and you're a medical provider and you have that expertise, you know how to offer more information. So if you combine how important is it you to calm these concerns, or would it be okay with you if I shared some information about COVID, or what do you know about COVID? Excellent, yeah. Thank you. If you're a counselor, you might be tempted to go to the mental health issues. I'm here, you might have a different approach. Yeah, I would be glad to help with your permission. Sheila, thank you. And Doreen, hi, Wendy. Yeah, ... Yeah. I'm so glad you were here to talk with me today about your fear about your husband. Can you tell me more about that's a nice reflection, potential reflection, Linda. You might say, thank you for allowing me to hear you talk about, which makes it a little bit more patient-centered, but you're expressing that spirit and style. I'm not fearless. I'm just over. Yeah. We have a series of health webinars. Yeah. When the person is ready. Now, in a counseling context, you would help with any ambivalence. So they kind of want to be there, but they're not quite sure if they should be there. And that's more of the mental health. Like, what are the anxieties that people are having, or the fears that people are having, and then present the information and the resources. Yeah. Oh, I like Patrick, I like the fact that you're telling them who you are. That helps. Like, this is my job, this is my role. What have you been told? And Is there something specific that is important for
People are.
me to know?
Yeah, they tell us that they're locking the front door on the dip, and you have to use your badge to scan in. You can't go there.
Yeah.
And they go, like, yeah, sure.
Yeah.
So I
Yeah.
was talking to the other girl, so
These are great. A reflection for Daryl might be your concern and care for for the people in your village is important to you. Sounds like it's very important to you, and you may want to find out what Western medicine can offer, but also that doesn't take away from what the community can offer. Yep. Yeah, and how can he role model for the community? Because his behavior is potentially very important for what villagers might accept. And also, what kind of suspicions might he have about Western medicine? What kind of perspective does he have about Western medicine that you could talk with him about? How might it benefit his family, to him, thank him? Yeah. Must be difficult worrying about that for Wendy, it must be difficult worrying about your loved one's health so far from family who could support you. Erin, that is exactly what I said. Think of me as a bridge for you to outside community resources. Not here to change what is healthy and works. Yeah, I did that exact same thing. Good job. That actually worked, by the way. It was pretty intimidating being an outsider coming into the community and wanting to support this woman and her struggles that she was getting a lot of pushback. Yeah. And I think, Teresa, that is very important. That's what happened in the village. And it was very important to be non-threatening, to be an adjunct. You're not taking away anything that the people found important for their daily life or how they might intervene with a healthcare issue. But it was the approach of adding to versus replacing. And bottom line was the villagers had to decide independently, which is supporting autonomy, you know, whether they were going to pursue the Western perspective or not. And that was really what needed to be communicated. I'm not here to, and that was from a villager. I'm not here to replace what we have done. I'm here to share what I've learned. And I think it could be helpful. And that was from the woman I was working with. That's what she ended up doing. Yeah. Yeah. Especially with something like a virus. You know, it's different with different healthcare issues, but with a virus that affects the body the same way. Can Western medicine offer relief and support in addition to other practices? And if you remember back to the smallpox, where it decimated whole villages and tribes, then it would be important to offer that type of medicine to the community, because somebody said it earlier, we're all human beings. It was in our prayer with Patrick. We're all human beings and we're all suffering with this together. Yes. While you're supporting his traditional practices, and also to find out what his traditional practices are, because you might come from a different perspective based on your tribal knowledge, and what is it that connects us, and what is it that keeps us connected. And one tribal community is not going to have the same practices. So if you're not familiar, as I wasn't familiar with the village I was in. I actually went to the village and spent time with some of the people, and was able to see the difference between what I experience and what other people experience. Yes, it has. Yeah. Yeah, Bonita, that is a major problem, is that fear. What has been proposed to reach this population? That's a good question. How about others? What have other people hearing about that? What are people proposing to reach the population when they're afraid to go in for care? I know that there's some initiatives going on at the national level, but it doesn't necessarily translate. Hi, Roy. Yeah. Oh, that's from Kevin. Okay. This is something that your comments are excellent, and I appreciate them. Thank you. Are there any resources in response to some of the comments that people would like to share related to people staying at home and how to engage them to get medical care? What are people's experiences with that?
And folks, you can unmute too if you'd like to comment verbally. Yeah. Yeah, good responses. The responses are fantastic. They're coming in.
Yeah.
I'm trying to respond as best I can, Doc, while you're presenting. This is great.
Teleconference and telehealth appointments. Thank you for saying that. Big thing right now, and I know there's some initiatives on the national level for Native communities if they have access to technology or a phone even. doesn't necessarily need to be a computer or an iPad. It could be just a telephone. It can be used very successfully in those kind of formats. Just kind of doing what we're doing, really. So thanks for that. Yeah, oh, okay. Free bus and transportation to the appointment, if that's available.
Kathleen, it is in the transportation company, Connecticut Transit, has provided access for folks to get, you know, the bus for free, and so that they or provide them with a bus pass if they don't, you know, because a lot of people have lost work, but they still need to get to certain medical appointments. So that is one resource that we are we have available here in Connecticut.
Oh, perfect. Yeah. And it's that's the key, is to make it accessible.
It's really important because I work in a methadone clinic, and even though we've staggered folks and given them bottles, a lot of them still need to get there at least every other day, and we don't want to set up more barriers.
No, not especially. I worry about the people that are getting opioid treatment, that they get their medications, because it could be really hard on them otherwise. Yeah, asking permission to even contact somebody, even to just say hi, especially if someone's a little hesitant or nervous about talking to someone outside their family or community. It's showing care and concern. And, you know, Paula that's kind of what I was thinking too, is you can do the best you can, but it's still an individual or family decision. And our job is to help them think through that decision, and to offer options for them based on some of the reality of the community, like free transportation, technology, access to technology, conflicts around what kind of medicine would be helpful, and does even Western medicine have anything to offer, providing information about the nature of viruses, and that it's not, someone said that earlier, it's not, it has no boundaries, it doesn't acknowledge race or ethnicity or gender or anything. It's the human condition. Right. That's kind of what I'm hearing. A lot of people don't have access to computers. So do they have access to phone? Yeah, telephonic counseling. That is the primary mode that people are using. It's Roy, I think you were mentioning earlier about using diverting some of the funding available to, if possible, to buying technology for people, but then they'd have to have access to the internet as well.
Yeah, there's a number of ways to go about doing that. So the guideline, I'll put out the guidelines first and then how to kind of work within those. You can't purchase the technology for the client to like take home with them. Like you can't buy them a track phone, you can't buy them a computer or anything like that. Nor could you do it for the family. In the instance of the convalescent home, what they've done is they've set up tablets for the patients there, and this could be done in the hospital as well. And then you can have a secure area outside that's safe and sanitized and social distance, where the family could actually come in, get on a tablet, and speak face to face with their family member that's there. Things like that can be done. There is a big question about buying minutes for those track phones and how that works.
Yeah.
The answer that we got on the FAQ call yesterday for funding, and it's kind of bounced back and forth. If the person is a client, say a substance abuse client, you're doing a GIPRA on those, it's allowable to do incentives for completing the GIPRA, both at intake and then their follow-up GIPRAs as well. So you could purchase those phone cards as part of their incentive for doing those GIPRAs and those follow-up GIPRAs. Incentives are okay. It can be in the form of a phone card or a gift card or something like that that they can use. So there's kind of a loophole in there. If you're doing a gift card, well, it's up to them how they're going to use that gift card. You could even do a gift card and a phone card, something like that, so you can stay in touch with your clients and do it that way.
Okay, that's very helpful.
Thank you, Roy.
Oh, yeah, this issue about testing, the lack of testing, and I hear that all over. A lot of people may have this virus, but they don't have the ability to confirm it. They don't have the resources. One suggestion, do people have access to masks, either cloth homemade masks or other types of masks, so that if they are worried that they have this virus, they have a way to keep their family safe or their community safe? In Oregon, we are expected to wear masks outside if we can't keep distance, 6 feet distance.
Hey, this is Roy again. Can I jump back in on this?
Uh-huh.
That's another area for funding where funds can be diverted to. I've kind of got some contention with it. You can only buy PPE for your staff. They're not allowing PPE to be purchased for the clients, but it raises the question, what if the client is coming into your office? Then you need to give them PPE to protect your staff for while they're there. So nobody's really addressed that question yet. Some really great information on this. There is a twice-a-week conference with the ECHO COVID conference out of the Northwest area in Portland. And if you can get on those conferences and listen, they've got a lot of really great information on how all of these questions are being addressed and what people are doing both in the behavioral health and the medical area on that. Kind of the general idea is assume everybody's positive until you know otherwise.
Right.
That's what it comes down to. Assume everybody you meet, everybody you talk to, everybody you deal with is positive until you have a confirmation otherwise.
Yeah.
Thank you, Roy.
Okay.
I'll see if I can pull up a link for that COVID conference, and it's, like I say, it's every Monday and Wednesday, and it's really good information. If I can find that link here, one of the links for it real quick, like I'll paste it in the chats.
Okay. We have about 8 minutes left, so I'd like to talk about what you can do after our first session here. I don't know if people can see that. I'm gonna get rid of that. So part of learning MI and benefiting from doing an MI approach would be to use it and to keep track of what you're doing. When you're first learning MI, it's practice, practice, practice. And you'll practice one skill, and then you'll build on that skill, and then you'll build and so forth. So here's some suggestions. There's other things, whatever you're open to, but generally I find that training alone isn't going to
necessarily transfer to practice. So you might have to, if you have access to, if you're seeing people via the telephone, or you have video, or you see people like in the hospital or a clinic, and you sense that there's any ambivalence or concern that interferes with your ability to provide that care to that person, practice using just spirit and style with open-ended questions and reflections for the week. Roy has mentioned, I have a few websites, but also Roy has actually more specific websites and materials that we can benefit from, share with each other. If you have one of the texts, and I'll show you before I end this what they look like. And I would just go and review sections that were covered in the presentation on spirit and style, and this is all about the engagement process of change. Next week, I hope you'll come next week to share, create an activity to share with us in our group next time. So prepare a quote, share a poem, story, image that you would like to share with us. And if possible, practice with a friend, colleague, with a real issue using engagement strategies for yourself, and then let us know how it went for you. But here's some ideas. There's probably a lot more ideas that you can all agree to keep this alive in terms of the learning process. I want to fast forward to the books, because we'll pick this up. We're going to talk more about ambivalence next week, and here's some of the pictures of the books. The book that I like for people who are working in a healthcare environment is called Health Behavior Change, A Guide for Practitioners. These are brief intervention tools that are suggested. One, you're using spirit and style, but you're also identifying a focus. Your primary job is try to resolve any ambivalence around the focused behavior. You're assessing for readiness. Next week, we'll talk about the idea of change talk and planning for change, which are the evocation and planning processes of change. I have a few activities that I can share and handouts. And then these are the books that I work from. Many of you might have already seen. This is the 3rd edition of MI. Then there's Motivational Interviewing in Healthcare. There's MI in Groups. And that's really more for if you're running groups, how do you have a motivational group? And then a motivational interviewing within the mental health population. So these are the visuals of those books, which you'll get in an email. So let's see. That's a little preview of what we'll talk about next week.
That's just a tantalizing preview for next week. Thank you.
Yeah, next week.
Yeah.
So any final comments or questions or responses? You have about a few more minutes for that.
I just want to jump in real quick, and a couple people were asking about getting this information. We're gonna we are recording this session, so we will share with you a link to the recording so you can review this and share it with colleagues. And we'll have handouts of the slides there too. And then we'll also include, we'll kind of take all the resources and things shared in the chat and put that in a document. So that'll be a little bit easier to access. So we'll try to send that out in the next couple of days. We'll also have a link to a quick survey about today's session. So I actually just put that in the chat. I'll I'll do that again here a second while I'm talking. So if you wouldn't mind taking a couple of minutes just to fill out a survey about today's session, we'd really appreciate it.
Yes, thank you. And all of you, thank you so much for your time. I very much enjoyed hearing from you and listening to you. I hope to see you next week.
Likewise. Can't wait to talk. I'm gonna get in there, Kathy. We're gonna figure out a way to get me to talk about ambivalence.
That's right.
Yes,
That's right. Kevin's our ambivalence man.
He's an expert on ambivalence. He's
I'm not ambivalent about ambivalence.
yes, and I have to practice saying Puget Sound too for next week. So.
Puget Sound, yeah, it's an Indian
You got
word.
it. That's your cat.
Logged me up right there. I want to thank Dr. Tomlin and Kevin, and I also want to thank Kate and everyone in the listening audience. Really fantastic. I'm glad our co-director Sean Baer was able to listen in, and just
Hey,
really
Sean.
wonderful to have everybody on. And we'll see you all next week, same time, next Thursday at 11 Central, 11 to 1 Central, and look forward to going through additional information from Kathy and Dr. Tomlin. So thanks again.
Thank you, everyone.
Surveys, and,
Thank you.
Be well.
everybody stay
Be
healthy.
well. Stay
Okay.
safe. Be well.